Yeah, we're going to be talking about antibiotic durations, but I'm going to approach it from a unique angle. So I'm not going to be regurgitating guideline recommendations to you because that's not the point of this presentation. So instead, I'm going to be picking apart the very system that we base our treatment durations on. So let's get started. My disclosures have not changed since my last presentation in June of this year. So I only do academic and clinically relevant talks to promote rational evidence-based medicine, and sometimes I receive honoraria for them. Okay, here are the objectives. We're going to learn about how we pick antibiotic durations in practice, talk about the limitations of our system that we base our durations on, and then finally I'll show you what I mean by optimal duration and discuss whether or not it's possible for us to achieve it. So for those who are interested, please have a look at the article I wrote for BCMJ earlier this year on this very topic. So the presentation today includes a lot of the content from this article. Okay, let's start with this case. You have a 35-year-old female. She's diagnosed with left leg cellulitis. She is correctly prescribed cefadroxil 500 milligram BID. On the 5th day of treatment, her symptoms have dramatically improved, but she reports residual discomfort, heat, redness, and swelling to her left leg. She's otherwise well. How many days of antibiotic do you recommend for her? Okay, so there's a good mix between 5 days, 7 days. 7 days appears to be the most popular vote, and then 15% shows 10 days, 1% shows 6 days. So the evidence-based answer is somewhere between 5 to 7 days, but as expected, most people choose 5 or 7. Rarely do I see someone consciously choose 6 days, even though that's still a correct answer. The persistent symptoms and signs of inflammation might prompt some people to extend treatment to 10 days, which is not necessarily the right thing to do. So I'll show you later how our immune system can actually fool us into thinking that infection is gone or still present. So I'm going to tell you the story about a psychologist by the name of Dr. Daniel Gilbert. He wrote an article in the New York Times about his experience with an antibiotic prescription, October 16 of 2010. So he's a psychology professor at the Harvard University. He went to the emergency room with a minor ailment and got 1 week of antibiotic. Being a psychologist, he rightly asked, what I didn't understand was why a full course took precisely 7 days. Why not 6, 8, or 9.5? Did the number 7 correspond to some biological fact about the human digestive tract or the life cycle of bacteria? So that's a very important question, but it rarely gets asked or answered in practice. So if someone were to ask you this question, think about how you would answer it, and feel free to post your answer in the chat if you would like. So 6 days later, October 22nd, Paul Sachs, who is an editor for the New England Journal of Medicine Infectious Disease Journal Watch, replied to Dr. Gilbert. He said, the answer, Dr. Gilbert, is that this is highly specialized knowledge, rarefied information that only 100% board-certified USDA-inspected infectious disease doctors know. And since I'm concerned that your article might give readers the wrong impression about our scientific credibility, I'll now divulge what we've learned and how to apply it. So now he goes on to reveal the 7 golden rules for determining antibiotic duration. So get ready for this. Rule number 1, choose a multiple of 5, corresponding to the number of fingers per hand, or 7, the number of days in a week. So I think we can all relate to that. Rule number 2, is it an outpatient problem that is relatively mild? If so, choose something less than 10 days. After application of our multiples rule, this should be 5 or 7 days. So for example, community-acquired pneumonia, pyelonephritis, skin soft tissue infections, or sinusitis. Rule number 3, is it really mild? So much that antibiotics probably aren't needed at all, but clinician or patient are insistent. So then you break the 5-7 rule and go with 3 days. For example, uncomplicated cystitis in young women. And as you may know, bladder infections can just self-resolve in around 40% of cases. Okay, rule number 4, is it a serious problem that occurs in the hospital or could end up leading to hospitalization? So with the exception of community-acquired pneumonia, 5 or 7 days, 10 days is the minimum. So remember, this article was published in 2010, so it's outdated now because new evidence shows you don't have to treat hospital-acquired infections or community-onset infections requiring hospitalization for at least 10 days. So for example, uncomplicated gram-negative bacteria can be treated with 1 week. And for hospital acquired pneumonia and community-acquired pneumonia that requires hospitalization, treatment can be as short as 3 days. Okay, rule number 5. Patient not doing better at the end of some course of therapy, extend treatment, again using multiples of 5 or 7 days. For example, if 1 week doesn't work, try 2 weeks. If 6 weeks doesn't work, then what do? We double it to 12 weeks and bypass everything in between 6 and 12. Rule number 6, does the infection involve a bone or heart valve? So 4 weeks at least, or often 6 weeks for these types of infections. Note that 5 weeks is not an option because here the 5 and 7 cancel each other out and chaos ensues. So I would have to disagree because I've tried 5 weeks several times and nothing chaotic occurred, but you have to try it for yourself to find out. Trust me, it'll be fun. Okay, rule number 7. The following lengths of therapy are inherently weird and should generally be avoided. 2, 4, 6, 8, 9, 11, 12, 13 days, also 3.1415, etc. That's pi in case some of you may have forgotten it. So I'm guilty of breaking this rule all the time. I've picked all these weird numbers before except for pi. So notice that there's exactly 7 rules, same as the number of days in a week. Maybe it's a coincidence. Now, if you've ever taken an IQ test, you might have seen a math question like this at the top. You have a sequence of numbers, you fill in the blank. Don't worry if you don't get it, most people don't. The answer is 11. They're all prime numbers. So it makes mathematical sense. Now, what about antibiotic durations? So you got days and weeks. What goes in the blanks there? So 3, 5, 7, probably 10. Okay, for weeks, 1, 2, 4 weeks, 6, 8, maybe 12 weeks. So I wonder why we think that way. Does this even make mathematical sense? Now, what happens when you see a guideline recommendation that suggests 10 to 14 days? Do you pick 10 and 14 more often than the numbers in between? If you follow Paul Sachs's rule number 7, remember you shouldn't pick 11, 12, or 13 because those numbers are inherently weird. Now, some numbers are more convenient and pleasing for us than others, depending on the unit of measurement. So if you take the common number of weeks of antibiotic we prescribe and convert them to days, we end up with ugly numbers like 14, 28, 42, 56. I much prefer 15, 30, 40, 60. They just look nicer, rounder, and more visually appealing, don't you think? As for 7 or 8, I mean, both can be lucky numbers depending on your cultural background, so either one could be good. So how do we actually get 7 days in a week? So that's because in 321 Common Era, Roman Emperor Constantine the Great said so. So prior to that, there were 8 days in a week. So why 7? Oh, because it corresponded to the number of celestial bodies that were visible to humans several thousands of years ago. So this included the sun, moon, and 5 other planets. And also the number 7 roughly correlated with the lunar cycle of 29 days. So now we choose durations that are based on Constantine units. 1 Constantine unit equals 7 days. And in ancient times, there were also 10-day weeks, 13-day weeks, but somehow the 7-day week dominated. And so because humans have 5 digits per limb, we often choose durations that are multiples of 5 or 7 for convenience. So consequently, our preference for particular treatment durations are not really based on science, but based on the way we organize numbers in our minds. So we think in chunks of time based on arbitrary human constructs. Now, according to psychologists, humans evolved in such a way that we're all prone to magical thinking. So when magical thinking applies to numbers, it is called numerology. This is a strong faith in the divine power of certain numbers when no such power exists. So we often tell patients, finish your full course of treatment. But what actually constitutes a full course? So it's actually arbitrary. We pick numbers that are convenient for our minds to understand, right? If it's arbitrary, then we can make up anything we want, right? So who is to say that your arbitrary duration is better than my arbitrary duration? So reality check here. Do you think biology, physiology, or microbes care about our arbitrary units of time? So I'll tell you an example. I saw an elderly man who had limited mobility. He was diagnosed with infectious endocarditis. He was coming in the hospital on the outpatient clinic every day for IV treatment. And the plan from the previous doctor was 6 weeks of antibiotic, although I felt that 4 weeks would have been sufficient according to the guidelines. I saw him 4 days before he was scheduled to finish his antibiotic, and then I offered to discontinue treatment that same day. so that he does not have to come into the clinic for another arbitrary 3 days that I think were probably unnecessary. So his daughter was there. Daughter told me that, no, I prefer that my dad complete the full 6 weeks, as that would give her peace of mind. So this idea of a full course is not a scientific one. It's a psychological one that gives people comfort. And so when I offered to stop treatment earlier than originally prescribed, it feels like I'm taking something away from them. I've disrupted their sense of completeness. But in reality, I'm just trying to tell them that they're being overtreated and we should stop it now. Okay, let's further illustrate this absurd concept of antimicrobial durations here. So these are all the planets of the solar system and the number of hours it takes for each one to complete a full rotation about its axis. Notice that some planets spin very slowly, like Venus, which one Venus day equals 243 Earth days, while others spin faster. So a day on Saturn lasts only 10 Earth hours. Now, if humans had evolved earlier on Earth, say 2.5 billion years ago, days only lasted 18 hours. Or if humans evolved on a different planet, our concept of time would be totally different. Now, in 1 billion years, if Earth is still alive and humans still exist, it is estimated that a day on Earth will last 30 hours. So 1 week course of treatment today is 24 hours times 7 days, that's 168 hours. I did the math, don't worry. If you wanted to maintain the exact same duration 1 billion years into the future, you would need to prescribe 5.6 days of treatment to get that same 168 hours. Now, if humans ever become an interplanetary species, we probably would need to recalibrate our antibiotic durations to correspond to the rotational speed of the planet we lived on. So now let's say you wanted to prescribe 7 days of treatment on Earth. That's 7 Earth days, obviously. What if you wanted to prescribe 7 days of treatment on Venus? Well, 7 Venus days is equal to 4.7 Earth years. That's insane. What if you live on Jupiter, you wanted to prescribe 7 days? Well, that's equal to 2.9 Earth days. What about Mars? Well, actually, 7 Mars days is roughly 7 Earth days, so no calibration needed. Okay, next question for you guys. You should finish the entire course of antibiotic even when you feel better. True or false? Well, I'm surprised. It's almost 50-50, with a little bit more people choosing false. That's interesting because this is a common direction that we give to patients. So according to the literature, many patients receive too much antibiotic. In essence, patients are being told, overtreat yourselves even when you're feeling better. So it was previously thought that a longer duration was needed to prevent relapse and emergence of antibiotic resistance. But now we know that longer durations don't necessarily prevent relapse, and it actually increases the risk of drug resistance due to prolonged exposure. And then considering that many patients get too much antibiotics than what the guidelines recommend, and we don't really know how to accurately individualize treatments, it is conceivable that this piece of advice is never correct and may in fact be harmful. So now we're recognizing that the opposite advice is true in some cases. So stop the course of antibiotics when you are feeling better. Problem is, what does feeling better mean? So this is one example. This is an RCT of inpatients with community-acquired pneumonia. They were randomized to stop treatment on day 3 or continue antibiotics for 8 days if they had met all clinical stability criteria on day 3. They found that 3 days was just as good as 8 days in those who met clinical stability criteria. So that's on the far right there, basically normal vital signs and GCS. And so for pneumonia, this is what feeling better means. It did not include white count, it did not include CRP, did not include cough, it's just vital signs. So it would be nice if we had similar stability criteria for other infections to guide treatment duration. Now let's look at antibiotic durations graphically. So quantitative variables like height, weight, they all follow a particular distribution when plotted on a histogram. The same is true for antibiotic durations. So you take, for example, gram-negative catheter-related bloodstream infections. In this study, patients received anywhere from 7 to 39 days of treatment. And what you'll notice is that there are 2 peaks, 14 and 15 days. So here you clearly see a preference for 2 weeks. I think 15 days was meant to be 2 weeks, depending if you count the first day of treatment as day 0 or day 1. But there's clearly a preference for 2 weeks, as Paul Sachs predicted. Second example, inpatient community-acquired pneumonia. Treatment range anywhere from 3 to 28 days. So notice that there's a cluster at 9, 10, 11. Prescription likely meant to be 10 days, but ended up with 9 or 11 due to a counting error perhaps. And then there's another cluster at 13 and 14. Again, likely meant to be 2 weeks of treatment. Now, in a survey that was published a few years ago, they sent it out to participants asking them, how many days of treatment would you prescribe for these common bacterial infections? So skin soft tissue infection, community-acquired pneumonia, cholangitis, pyelonephritis, bloodstream infection of unknown source. 170 out of 221, or 77%, completed the survey. 60% of them were infectious disease doctors. And you'll notice that there's a cluster at 5, 7, 10, and 14. So these guys take Paul Sachs's rules very seriously. There are a few people who picked 2, 3, 4, 6 days. Not sure if they were just goofing around with their answers, or maybe they misclicked, or maybe they know something the rest of us don't know. Consider this hypothetical situation. Suppose you have 1,000 or 10,000 patients with a common infection like pyelonephritis, and you have a magic 8-ball that tells you exactly how many days it takes to cure each patient. Now you plot this data on a histogram. So you end up with a normal distribution. It doesn't have to be a normal distribution. I'm just using this type of distribution for this example as it's easier to work with. All right, so have a look at that. And then answer this question. If you are writing a recommendation in a guideline, what length of treatment do you recommend? Do you suggest 6 days, which is the average or median? 8 days, which is just over the 90th percentile? A range, 5 to 7 days, 1 to 10 days, or D, other? And if you choose other, I'm curious to know what your thoughts are. You can post in the chat if you like. Okay, so we have a pretty good split here between 6 days, 8 days, and a range. Okay, so let's go through this one by one. Okay, so A, only half of patients will be cured with 6 days. That's no good. What about B, 8 days? So that means at least 90% of patients will be cured. But the problem is you're over-treating most patients who need 7 days or less. So these fixed durations are problematic, aren't they? Okay, C, how about a range? So to me, that seems to be the best answer, but it fails if the clinicians don't have the same magic 8-ball as you do and can't figure out exactly how many days of treatment their patient requires. Or sometimes they just pick numbers at the end of the range, like the 10 to 14-day example I alluded to earlier. And then for D, if you have thoughts about what else you would do, just maybe post in the chat. So another question to consider is, does the drug class affect the duration of treatment? So it probably does, because all drugs have different half-lives, varying degrees of tissue penetration. They all kill pathogens at different rates, and they have different interactions with the immune system. So here's an example of acute bacterial cystitis. You can treat it with 3 days of Cipro or Septra, 1 dose of fosfomycin, or 5 days of nitrofurantoin. So ideally, when you make a recommendation on treatment duration, it would be nice to stratify by drug class. But for most infections, guidelines don't really do that. What about the type of pathogen involved? Does that affect duration? So sometimes it does. So here's an example of infective endocarditis. So some bugs are easier to kill than others and require less antibiotic exposure overall. But not every infection is stratified by pathogen type. How about patient factors? So these matter as well. So for example, in pediatric osteomyelitis, treatment can be as short as 3 to 4 weeks. Then adult osteomyelitis, which often is treated with 6 weeks of treatment or even longer, presumably because kids heal bone faster. Another example is immune status. So for example, with pyelonephritis, 1 week of treatment is usually sufficient for immune-competent patients, while guidelines recommend 2 to 3 weeks, based on limited evidence, for infections of a transplanted kidney. Now, even with guidelines, treatment durations in practice are often longer than necessary. So for 3 common infections, cellulitis, acute bacterial cystitis, and community-acquired pneumonia, the recommended treatment durations at the time of these studies were published, they were all less than or equal to 1 week. But prescribers often gave longer courses, sometimes double the length that was recommended. So I can attest to this same observation in my own practice. It seems that treating longer than required is almost like the standard of care in some places. And the reasons for overtreating are complex, but likely involve psychological factors, institutional or cultural pressures, maybe not keeping up to date with the evidence, etc. So that's why we have multiple RCTs now that have shown shorter durations are just as good as longer durations for many types of infections. So you can see that there is a fixation on certain numbers in these studies. Durations that are multiples of 5 and 7 are chosen for comparison between the short and long treatment arms, even though the study investigators can choose any numbers they want, right? Oops, sorry. There's nothing magical about multiples of 5 or 7, right? It's important to keep in mind that if the non-inferiority is demonstrated with the short duration, it does not mean the short duration is the optimal duration because optimal duration varies from person to person. So it wouldn't be wise to assume that a fixed duration of treatment applies to every patient because the differences in host and microbial factors will affect the time to recovery. I'll talk more about optimal durations later on. Now, some folks are brave enough to break Paul Sax's rules. So in a cellulitis study, they compared 6 versus 12 days for inpatients. And in a ventilator-associated pneumonia study, they compared 8 versus 15 days. And guess what? Nothing bad happened when they broke the rules. The world didn't end. Patients still had good outcomes. Now, I think these investigators were really thinking outside the box. Now, if fixed durations are inadequate, how about using biomarkers to guide treatment duration? So common biomarkers are procalcitonin and CRP. In one large RCT of ICU patients with sepsis or septic shock, they were randomized to receive procalcitonin or CRP-guided treatment or standard of care. Basically, the clinician can pick whatever duration they want. Only the procalcitonin-guided therapy led to a statistically significant difference compared to standard of care by almost 1 day reduction in antibiotic use. CRP did not help shorten duration at all. In the second RCT, patients were randomized to CRP-guided treatment, a fixed 7-day course, or a fixed 14-day course for gram-negative bacteremia, uncomplicated. The median duration of treatment in the 7 and 14-day group were as expected, 7 and 14 days. Interesting, the CRP-guided group, it failed to shorten treatment below 7 days. So these graphs pertain to the gram-negative bacteremia study I just talked about. So if you look at graph B and C, the vast majority of patients in the fixed treatment arms got 7 and 14 days as expected, although a few of them deviated from protocol. Graph A shows the CRP guidance. So even though the median duration is 7 days, you can see that the range is much wider. So CRP guidance can actually shorten duration to less than 7 days in some patients, but it is more likely to prolong duration beyond 7 days. So CRP is only useful if it can shorten duration to less than the fixed 7 days, but you don't know which patient that will be. So the question is it worth measuring serial CRP on every patient for the sake of antimicrobial stewardship at the expense of laboratory stewardship? You're poking the patient a lot more now just to monitor that serial CRP. So in other words, is it justifiable to order a lot more CRP tests to find those patients who can have their treatment shortened by an extra 1 to 2 days, or just give everyone 1 week of treatment? So I'm not too sure about that. I just tend to give everyone 1 week of treatment for uncomplicated gram-negative bacteremia. I don't even bother with serial CRPs. So are fixed treatment durations better, or is biomarker-guided treatment better? So here's a side-by-side comparison of RCTs that look at fixed short versus fixed long durations and biomarker-guided versus standard care. So the first example is ICU patients. So the fixed short duration is non-inferior to the fixed long duration for ventilator-associated pneumonia, intra-abdominal infections, and gram-negative bacteremia, ranging anywhere from 6 to 8 days. And then biomarker-guided therapy in ICU patients with sepsis or septic shock from any source, it shortened treatment duration by 1 day. That was the procalcitonin study I talked about earlier. But the procalcitonin guided arm, it was still longer by 2 to 4 days compared to the fixed short durations in the RCTs for VAP, intra-abdominal infection, and gram-negative bacteremia. Okay, moving on to non-ICU gram-negative bacteremia, the fixed duration, 7 days, is no worse than 14 days, which matches the biomarker-guided duration of 7 days. That was the CRP-guided gram-negative bacteremia treatment I was talking about earlier. And for CAP, community-acquired pneumonia, treatment can be as short as 3 days using validated clinical criteria. But if you use biomarker guidance, look at this, it actually prolongs treatment to almost 8 days compared to standard of care, which is 7.2 days. It was not statistically significant. So we have many of these RCTs for various infections where the short arm is just as good as the long arm, making treatment guided by currently available biomarkers somewhat obsolete. Now, in the 1970s, patients got ultra short treatment duration for things like pneumonia. I was able to find that they got like oral ampicillin, 2 grams BID plus probenecid, 1 gram BID for just 1 day, and the cure rate was like 90%, which is similar to the cure rate of modern antibiotic duration. So somehow we end up with treatment durations that were far too long for common infections. And now we're trying to prove to ourselves that we can get away with shorter courses for most infections. So there are many benefits of shorter treatment duration. You got lower risk of antimicrobial resistance, lower costs, reduced risk of C. difficile, reduced risk of drug side effects, lower greenhouse gas emissions, especially with IV antibiotics. And overall patient adherence is better because the longer that they have to take antibiotics, the higher the risk of non-adherence, especially when they're starting to feel better. So how long do you treat the patient's infection? Well, this is one of the most common questions I get, if not the most common. So it can't be that hard to figure out, right? Because you can just look up the answer in a guideline. But the optimal duration, like I said earlier, varies from patient to patient. So this is the minimum number of days, weeks, or months of antibiotic required to cure the patient of their infection. So in many of these RCTs, they compare one fixed duration with another in a population setting. So they don't actually find the optimal duration for each patient. Whereas in some of the more recent studies I've shown you, they are attempting to individualize treatment duration by using, say, biomarkers. It's far from perfect because they often don't perform better than fixed short durations and might inadvertently prolong treatment unnecessarily. But the fixed durations, as we know, are also inadequate because they likely lead to over-treatment of most patients, as illustrated in that hypothetical scenario I showed you earlier. So what we really need are tools that can accurately predict the least amount of antibiotic needed to cure each patient. So as I like to say, treat until the patient is cured, not until the calendar aligns. So let's go back to the first case. This is the 35-year-old female with the left leg cellulitis from question 1. She completes her course of antibiotic as prescribed with excellent clinical response. Now she asks you, is my infection all gone? How do you respond? A, yes, because your symptoms have improved or resolved. B, I'm not sure, but let's do a blood test. C, even though your symptoms have improved or resolved, there might still be bacteria present, so we gotta watch carefully for signs of relapse. D, I can't prove with complete certainty that your infection's all gone. You finished the standard course of treatment with a good response, so I'm optimistic that you're adequately treated. Okay, so most of you picked answer D. Second most popular answer was C. So let's go through this one by one. So answer A. This conveys certainty when there isn't any. So patients prefer black and white answers. But often in medicine, things are in the gray zone. So we don't have black and white answers. So I never answer this type of question with a firm yes because nobody can be 100% sure. B, there is no blood test that will tell you the infection is all gone. So what blood test will you actually do? Like white count, CRP? These are inflammatory markers, not infection markers. How about C? So this is a true statement, but it doesn't convey reassurance to the patient, and so it might cause undue anxiety. So this is not something I like to tell patients either. So I prefer D. So this is the type of answer I often give to patients. So I admit when there's uncertainty, but also provide reassurance and optimism about their outcome. Okay, but how do you know when the patient is actually cured? So the problem is you don't. That's the reality. So the definition of cure is actually arbitrary, and it can include as many clinical, biochemical, microbiological, or radiographic features as you want. So the greater the number of criteria required, or the more stringent they are to satisfy your definition of cure, the harder it is for patients to achieve it. So let's remind ourselves what is actually the definition of an infection. So infection occurs when pathogens like viruses, bacteria, fungi, parasites, they invade host tissues and then multiply within them. Now, what is the gold standard for diagnosing infection? We often don't do this, but it's actually histopathology plus culture. So this is the best way to prove that an infection is present. Instead, we rely on indirect markers of infection. So like patient symptoms, physical exam findings, blood work, imaging. And when a patient is cured, that should mean the infection is gone, right? So from a microbiological standpoint, cure is achieved when the pathogens are no longer able to invade and cannot multiply anymore. But can you even measure this parameter using current technology? So remember, the goal of the antibiotic is to kill pathogens, and it doesn't take away symptoms, right? That's a secondary response to killing the pathogen. And the question that naturally follows is how much of the pathogen burden do you have to kill to achieve cure? 80, 90, 100%? Do we even know? So most patients have an intact immune system. Oops. They have an intact immune system. And so you're not relying only on the drug to do the work. But let's say you do have the answer. The next question is, how do you know when you have killed off enough pathogens? So you can have ongoing symptoms and signs of inflammation even when the pathogen is dead. So persistent inflammation does not necessarily mean there's ongoing infection. It's common for clinical, biochemical, and radiographic abnormalities to persist even after you've eradicated pathogens, because the healing process, like tissue repair, immune downregulation, symptom resolution, can take much longer. So on the other hand, the absence of inflammatory symptoms and signs does not include infection either, because patients' symptoms correlate poorly with pathogen burden. So the clinical, biochemical, and radiographic signs of inflammation do not give us an accurate information about pathogen activity, viability, or burden. For example, you can have persistent signs of inflammation following treatment of cellulitis. You can have ongoing cough after treatment of pneumonia. Sometimes fever can last up to 3 days or longer, even with effective treatment for pyelonephritis. And then for some infections like cryptococcal meningitis in AIDS patients who have very weakened immune systems, or latent syphilis, where it often avoids immune detection, you have no symptoms or signs of inflammation. Right? So this is how your immune system can fool you. So here's an example of how persistent inflammation does not mean you need longer treatment. So this RCT is called the STOP-IT trial. It randomized over 500 patients with complicated intra-abdominal infections who had adequate source control to the intervention group, which is a fixed 3 to 5 days, where they had a median of 4 days, or the control group, where antibiotics were continued until 2 days after normalization of inflammatory signs, defined as resolution of fever, leukocytosis, and ileus. And the median duration was 8 days. The primary outcome of surgical site infection, recurrent infection, or 30-day mortality was similar between the two groups at just over 20%. So presumably some patients in the intervention arm still had symptoms and signs of inflammation when their antibiotic was stopped. The exact details were not provided, unfortunately, but they did just as well as those who had antibiotics continued until resolution of inflammation. So in these RCTs, we measure things like 90-day all-cause mortality, antibiotic-free days, symptom resolution, improvement in clinical, laboratory, or radiographic findings, which makes sense from a patient perspective. From a microbiological perspective, these parameters are fundamentally flawed because none of them tell you how much of the pathogens have been killed off by the antibiotic and how fast it's happening. So the primary effect of the antibiotic is to kill pathogens, not to reduce mortality, not to reduce symptoms. These are secondary effects that occur from reducing pathogen burden. So in other diseases like, for example, cancer, we do imaging to monitor tumor burden, measure tumor markers. For diabetes, we're measuring blood glucose. hemoglobin A1C, COPD, or measuring spirometry or respiratory symptoms. So all these parameters make sense for the disease that you are treating. But for infection, we measure inflammatory markers, which are reflective of immune activity, not pathogen activity. And we also measure patient symptoms, but they correlate poorly with pathogen burden. Sometimes we use imaging, but the imaging does not tell us if there are bugs inside our organs. They only show signs of inflammation, tissue damage, fluid collections, etc. So ideally, like in a lab setting, we would measure things that are directly related to the infection itself. So it would be nice to have more infection type markers. So for example, rapid plasma reagent is a marker for syphilis activity. Not perfect, but still the best we got. Some patients are told that CRP is an infection marker, and we should use that to determine when infection is gone. But that is completely false because CRP measures immune activity. It does not correlate well with pathogen activity. I also wish we could measure pathogen burden, how much there is over time, how much we need to kill off so that we can allow the immune system to take care of the rest. And also how fast the drug is actually killing the pathogen, so then we can estimate when to stop treatment. Now, if we can only construct a time kill curve for each patient, then we would have a much clearer idea of when the patient might actually be cured. So we would be able to see how long it takes for each drug to reduce the pathogen burn. And then once it reaches near zero, then you can stop your treatment. Now, obviously, we can't measure these parameters in humans. It can only be done in a lab setting where the concentration of the pathogen and the antibiotic environmental conditions are controlled. And the killing effect is not complicated by the presence of an immune system. So some antibiotics interact with the immune system, either to dampen the immune response or to augment its effect. So for example, macrolides are anti-inflammatory. Beta-lactams might enhance the activity of the host antimicrobial peptides to kill the bacteria. So it's all very complicated. Here's a funny comparison here. So let's compare how long it takes to treat an infection to how long it takes to roast a turkey. So you place the turkey in the oven at 350 degrees Fahrenheit, roast the turkey for about 13 minutes per pound, or 15 minutes if there's stuffing inside. Now, the turkey is ready when the thermometer inserted into several places of the bird shows that it is at least 165 degrees Fahrenheit. So notice that there's no fixed duration. The cooking time is individualized based on the turkey's weight and whether or not it has stuffing. So 13 or 15 minutes per pound. And there's an exact and logical endpoint of this process that you can measure with some degree of precision. So when the turkey reaches a certain temperature, that's when you know it's ready. So I think we're probably better at cooking turkeys than we are at determining antibiotic durations. Now, for those of you who practice in BC, there are several resources you can access to look up antibiotic durations for common infections. So Pathways BC allows you to search for the type of infection you're treating. It'll give you some guidelines or links to guidelines. First Line and Bugs and Drugs can be downloaded as apps. You can also access the content from their website. So they provide local guidelines. They're periodically updated with new antibiograms and recommendations. So these are the resources I use myself. Okay, so here's some take-home points. So hopefully now you can see how absurd and non-scientific our treatment durations are. So, let's stay humble. Let's not have too much faith in our magic numbers. And with fixed durations, it's likely that many infections end up being overtreated, but we don't know who those patients are. And as a general rule of thumb, shorter is usually better for many infections as long as the evidence backs it up. I think we should stop fixating on certain numbers for our convenience because otherwise we might miss out on even shorter effective treatment durations, like 6 days instead of 7, 5 weeks instead of 6 weeks. And so these fixed numbers make our thinking too rigid when we need it to be flexible. So I think it's reasonable to experiment with a wider range of durations in clinical trials, not just the multiples of 5 and 7. If in practice a patient takes only 9 days of treatment and they feel great, even though they were prescribed 10, I don't worry about that extra day. And hopefully in the future, we'll have better, more accurate technology and perhaps with the AI to help us individualize treatment better and then slowly move away from these fixed durations. Okay, and with that, I am done. Happy to take any questions.
Thanks, Davie. So an excellent presentation, Davie. I love your presentation style. I'm just going to go through the questions one by one and then we can talk about them. one person didn't ask a question but posted a comment. Their general view is prescribe for longer than you think because the patients will stop the antibiotic after they feel better anyways. And I think you've addressed some of those points in there. Don't some cell cycles correspond to our cycles, perhaps because of development on the same planet or coincidence? So I guess thinking about that question, do we know anything about from microbiology about anything related to that time to kill or amount of kill or bacterial life cycles that could help us, even if not directly, but indirectly?
I mean, it's been studied in the lab, so you can measure concentration of bugs and an antibiotic, and you can construct such a time kill curve, right?
Hmm.
But it's in a very controlled environment, and you're looking at just two variables, the bug and the antibiotic. Everything else is controlled. It's hard to apply that same principle in humans because you don't know how much bug is there. You don't know how much antibodies reach the site of infection. The temperature
Hmm.
might be different. Acidity might be different, especially in an abscess. And you have your immune system, so it's all very complicated. So if you were to construct a time kill curve in a human, I don't think it's going to be as straightforward as it is in a a laboratory setting.
Sure.
So I think that in the future, if we end up developing better infection biomarkers that we can measure, that's probably the best we can do.
Okay. A couple of people talked about suggesting stopping when the patient feels better or when they felt better for 24 to 48 hours. Do you have any thoughts on that, if that's reasonable?
So that's already being done for community-acquired pneumonia. So that 3-day versus 8-day trial,
Hmm.
but it's only been kind of validated for pneumonia. I mean, for other infections, we don't really have such precise clinical stability criteria. And for other infections, it's a fixed 1 week or 2 weeks, even if you feel better. So the problem that I was alluding to is that we don't know what feeling better means for every infection. We know what it means for pneumonia, but let's say you had pyelonephritis. It's usually 7 days, right? Let's say you're feeling back to normal after 4 days. Do you stop? I don't actually know the answer to that. We need to do studies to see if that criteria is validated in that infection. So as of now, the evidence still suggests you do the 1 week, even if you're feeling back to normal on day 4, right? Because if the patient does relapse, it looks bad on paper that you didn't follow the guidelines.
Hmm. Previously, someone's commenting on previously, they were taught that if you stop the treatment course early, it promotes bacterial resistance. And you mentioned the opposite in one of your slides. So can you sort of summarize the evidence base for, or comment on the fact that resistance actually increases if you treat too long?
Okay, so the problem is the framing of the question, stopping too early. That's not the right question to ask because we know that many patients get treatment for too long. And so when you stop it early, what you're actually doing is stopping over treatment. You're not stopping early. You're actually trying to correct the treatment duration to a shorter course, the shortest minimum effective course. So I think when you frame the question this way, the patient feels like you're taking something away from them, which is not the right thing to do. So I would rather express that, like you've been on this for 10 days. Guidelines say you only need 5. I'm concerned you're getting too much antibiotic and it's harmful for you in this way, that way. And so you express it as a concern that they're getting too much so that they're not feeling like you're taking away antibiotics from them. And so this whole idea of finish the treatment when you're feeling better, um, it's not really scientifically grounded because we don't know exactly how many days of treatment each patient requires. But what we do know from the literature is that many patients get over-treated. So when you tell someone to finish their 10 days, even though they require 5, and you tell them to stop at 6, it's a misperception that they're stopping early, but in fact, you're actually stopping them from over-treating themselves.
Sure. And previously, when people were taught to continue till the end or resistance will increase, what was that based on? Was that just magical thinking as well? Or is there some basis for
So
that that's now been disproven to be false?
there's some historical basis to that, some pseudoscientific basis. So,
Okay.
in the past, when we first um, when these antibodies were developed, we didn't have RCTs. We didn't know how to study them properly. We didn't know what the optimal duration was or minimum duration. So when you're playing around with different durations, of course, you're going to have some relapses, especially for
Sure.
serious deep-seated infections like endocarditis or osteomyelitis.
Mhm.
Um, and so if you are perhaps using the wrong drug, underdosing it, doesn't matter what duration, you probably will have a relapse. Um, and so this concept maybe was misapplied too broadly across multiple infections. So things that are, can be treated with shorter durations like pneumonia, cellulitis,
Mhm.
this concept of treating more than what's necessary was misapplied.
Mm.
And so in infections where there is like um, uh, where you do actually need longer durations, like osteomyelitis or endocarditis, there is a real risk that if you only treat for like a week or two, you will have a relapse and the bacteria that regrows might be more resistant. So that's a real concern, but it's misapplied to infections that only require shorter durations. And so for those ones that require shorter durations, you
Yeah,
overtreat them, you're building more resistance.
got it. Okay, thank you. Someone's asked a question, can we stop antibiotics after a repeat blood culture is negative?
That question has a very nuanced answer and depends on what infection you're treating, what the source is. Um, there is no uh, general answer for that question. It really depends on what you're treating, what the situation is.
Okay. There's been a few comments with different sort of slants to them about what patients want to hear and with regards to the uncertainty, or do they want black and white information, more scientific information, or after COVID, are patients more comfortable and would prefer to understand and hear about the uncertainty? So what has been your experience, or do you have any thoughts on that?
And I think as humans, we all crave for certainty, right?
Hmm.
Even doctors. So I'm often asked by other doctors, "Are you sure there's no infection? Can you make sure you rule it out?" I'm like, really? So it's a human trait, not just a patient trait. And, certainty provides comfort. But I try to normalize the fact that in medicine, things are rarely black and white. Most often, we're operating in the gray zone. And we really should be thinking of risks and outcomes as existing on a spectrum of probability. So I don't use numbers when I talk to patients. I just tell them like it's very, very unlikely, or you've had very good treatment. I'm very optimistic that your infection's gone. So
Hmm.
use kind of words like that. I wouldn't throw a number at it. You
Okay,
can if you want, but never say 0 or 100%.
sure. Okay. So we probably have time for two more. I'm sorry to everyone that has posed a question that we won't be able to get to. I want to finish right on time. So one of those questions is, I find lower limb cellulitis duration tricky because those darn legs stay red. Other infections are easier if people feel better. Any wisdom or tips for lower limb cellulitis?
Yeah, this is one that's often overtreated because the limb stays swollen and red and painful for quite some time, sometimes weeks. That's normal. And this is going back to like how ongoing immune activity does not equal ongoing infection, right? So the difference between skin soft tissue infections versus other things like pneumonia and pulmonary is you can actually witness with your own eyes the natural evolution of cellulitis. If you had some sort of X-ray vision and you can visualize how your lungs or your kidneys are being destroyed by your immune system or bacteria, you might end up extending treatment as well. So the fact that you can see the cellulitis evolve and progress biases you towards longer treatment.
Um, Someone's asking, can you summarize how you prescribe antibiotic durations or follow-ups with your patients, or what you tell patients when prescribing for things like outpatient CAP or cellulitis, for examples?
I mean, I still follow the guidelines, right? So if the cellulitis guideline says 5 to 7 days, I try to give 6 days as equal weight as 5 or 7, right? And I'm conscious about that. I don't believe that 5 or 7 is better than 6. And I do tell them to finish the course because that is currently the guideline recommendation. I rarely where I say like after 4 days of treatment, And clinically, everything looks fine. Some people do respond that quickly. I tell them, okay, you're done. Um, but I wouldn't advise everyone to do that, because I have experience with this, and I'm more comfortable experimenting a little bit, and I recognize some of the limitations of some of these studies. I'm comfortable doing that, but for the rest of you, um, I would prescribe just the minimum duration that's recommended in the guidelines.
Okay, thank you. And maybe the last two questions. Does strep throat really require full 10 days of treatment?
I gave a talk about that a couple of years ago. The
Okay.
short answer is, let me rephrase that. Let's go back and ask this question. Do you even need to treat strep throat with antibiotics? The answer is
Uh-oh.
probably no. But if you look at the guidelines, they say yes, you give 10 days, but it's not universal. If you look at different guidelines across the world,
Mhm.
some of them say 5, 6. It's not universally accepted. Um, so, but just follow the local guidelines. I think it is also reasonable that if you're comfortable and you're familiar with the evidence, you can also um, offer the patient to not start antibiotics because uh, strep throat is a self-limiting illness. They've shown that antibiotics only shorten duration of symptoms by like less than a day. You
Mm,
get better bang for your buck by using NSAIDs or steroids.
mm,
And it's not easy for you to actually eradicate the strep from your throat. So the the main reason we treat it is to prevent rheumatic fever. But the data that supports the treatment for everyone is actually very old and is no
mm.
longer applicable in developed nations. So I won't go into too much detail about it.
Okay.
Um, but that is something that the emergency doctors have been questioning for a while. And unfortunately, this new data has not yet made its way into guidelines.
Okay. Thanks, Davey. It is 1 o'clock, but I did promise one more question. So maybe a very, very short answer. Is there a difference when we are treating an infection in tissue where there is good capillary function versus poor drug delivery into abscess, osteomyelitis, or topical infections, pharyngeal carriage, or skin ulcers? So do you need more intense treatment when there's poor circulation or limited access?
The site of infection will somewhat dictate the duration because some drugs don't penetrate as well,
Mm,
and it's harder to reach adequate drug concentrations. So, like abscesses, those are very difficult to treat with antimicrobials alone. They just don't work as well
mm,
if it's a huge abscess. So sometimes source control is the main treatment here. So you don't want to forget the other factors that are relevant for infection cure. So it's not just the drug that cures the infection. There's
mm,
other factors too, some of which you can control, some of which you cannot. So draining
mm.
an abscess, cutting away the infected implant, whatever that might be, probably makes a bigger difference than the duration of therapy. So that's
Got it.
why I don't fixate too much on the duration because sometimes it's not even the most relevant question.
Mm, okay. Thank you so much. Sorry to go over time, everyone. Davey, I really appreciate you coming back and doing a webinar. Again, amazing presentation. I think everyone really loved it. We'll probably have you back again.